All right, with this one, we're going to talk about the respiratory medications, upper respiratory, lower respiratory. Let's start with upper respiratory for now. All right, upper respiratory disorders. What's the most common upper respiratory disorder? And it's like literally right there on the page. It's your common cold. There's multiple variants of that virus, but most common upper respiratory disorder, again, is common cold. Also, sinusitis is a common upper respiratory disorder. Acute pharyngitis or sore throat, acute rhinitis, again, all very common upper respiratory things. And then what causes this? What's the most common cause for these upper respiratory disorders? And it's usually either allergies or viruses. So is there anything we can do for that? Is there a cure for the common cold? And the answer is no. There's not really a cure. We're really just hoping to help with the symptoms. The medications just manage the symptoms. There's no real cure for that. So that's the medicines that we're going to talk about. First one, we'll talk about our antitussive medications. So these are going to suppress the cough reflex. There's different types. You got non-opioid and opioid. Clearly, the opioid are not available over the counter, whereas dextromethorphan is available over the counter. The action is they act directly on the central nervous system to depress the cough reflex. So again, just remember two different types, opioid and non-opioid. The difference between opioids for antitussive purposes and opioids for pain relief is the amount. It's a much smaller amount of codeine in the cough syrup than when we're taking it for pain purposes. But all the same things apply. I mean, if you get too much codeine, you can still, or hydrocodone, cough suppression, you can still have all those negative adverse effects associated with opioids. Adverse effects. Dizziness, drowsiness, especially with those opioids, but even with the over-the-counters, potentially, but those opioid ones for sure. Dizziness, drowsiness. And then there's always a potential for abuse. Obviously with the opioid, the codeine, hydrocodone, but even with the non-opioid, there are kids out there that abuse those. And when I say kids, I mean usually teenagers or early 20s. Not to say other people don't, they certainly do, but they'll go out and get a whole thing of Robitussin and down it. DXM, which is dextromethorphan, overdose is possible. It takes a lot. The big scary thing with that is the kids will just go grab it off the counter. Again, they'll see, this is, it's got the dextromethorphan. That's the stuff they want. They won't notice that there's also acetaminophen in there. Not every preparation has that. Sometimes it's just the dextromethorphan, but sometimes it is, or a lot of times it will be combined with acetaminophen. Now we're really in danger. If you down a whole bottle of that with acetaminophen, now your liver is in extreme danger, especially if you're going to go out and drink on top of that. Not the best idea, but unfortunately you will see that happen. So there is abuse potential. Certainly with the opioids, we just know that, right? And that's just common knowledge nowadays. What's not so common knowledge is people will abuse DXM for purposes of getting high. And we need to just realize that that's a potential there that we need to keep in our head. Contraindications. If someone needs that cough to maintain their airway, cough a lot of times is a good thing. If we've got like this, if we've got a lot of buildup in our lungs and we're coughing out, good amounts of secretions, we don't want to suppress that, right? So if we're doing this to try to maintain our airway, or those people with like asthma and COPD, especially those with COPD that have that cough that are constantly there to try to maintain their airway. We certainly wouldn't want to take that away from them. And then if they've had a head injury or impaired central nervous system, it's not a good idea to go ahead and take these as well. Be careful in people with a history of substance abuse. These can interact with other CNS depressants, just like we've talked about with other meds. So if it causes that dizziness, drowsiness, we wouldn't want to compound that with further medicines. It's going to depress that CNS system. And these can also interact with MAOIs. MAOIs are a type of antidepressant that we'll talk about later when we get to antidepressants. They really interact with all kinds of medicines. So we'll really don't worry about those so much now. Just know that antitussives can interact with those. Patient teaching. These are, again, for short-term use. If you have a long-term cough and you've had it for weeks and you can't get rid of it, that says there's something more going on. So if someone needs these for more than 5 days, really they need to go talk to the doctor. There's probably something else going on. So again, short-term use, just short-term use to help relieve the cough. Avoid alcohol, and then always read your labels. Because again, these are common over-the-counter medicines, especially the dextromethorphan. But a lot of times it's not just dextromethorphan in there. There's other medicines in there, and we need to make sure we're not getting too much. Same if we're going to take this plus other combo meds, we may be getting too much dextromethorphan because it's also in these other combo meds we're taking. Decongestants. There's a couple different decongestants. These are also over-the-counter meds. However, the pseudoephedrine is now kept behind the counter, and you have to sign papers, and you can only have so much pseudoephedrine at a time because it's actually a common ingredient in meth. People that make meth, interestingly enough. There's the two different types as far as nasal and systemic. And it's important to know those because there are different adverse effects associated with those. So what we're really trying to do here is cause vasoconstriction and reduce the amount and size of the nasal mucosa membrane. So we're just trying to reduce that swelling there of the nasal mucous membranes. And we do that either directly, which is nasal, or through or systemically. Our indications, again, just that nasal congestion. Adverse effects. It just depends on how we're taking it. Are we taking it nasal or topical, or are we taking it systemically? With the topical medications, the big adverse effect that's associated with that is rebound nasal congestion. People that take it, especially if they take it for a long period of time, once they stop, the nasal congestion comes right back, and it can be worse. The systemic ones, pseudoephedrine, that can cause CNS stimulation, can just cause stimulation of a person, so it can actually increase heart rate a little bit, just make us feel kind of nervous. So CNS stimulation or sympathetic effects, if you want to call it that, are associated with the systemic ones. Contraindication. So if you have uncontrolled or severe hypertension, you wouldn't want to take these, especially the systemic. Coronary artery disease, because again, remember, we're causing vasoconstriction. So if you have coronary artery disease, especially the systemic ones, we would want to avoid. Be careful just in anything that can be exacerbated through these systemic effects. So anytime if somebody already has problems with like irregular heart rate, especially if it's a tachycardic, but any sort of irregular heart rate, anything that's going to be potentially exacerbated by this stimulation activity. It's going to interact potentially with beta blockers, interact potentially with caffeine, which makes sense, and then MAOIs again, because MAOIs, almost everything interacts with those. As far as nasal decongestants, those can actually interact with some anesthesia. So we would certainly want to know if they're taking these before surgery. We want to make sure we're doing a good med reconciliation and ask about those. Patient teaching. We want to teach them how to use them, especially if they're using the nasal drops. And then, of course, no more than 3 to 5 days, certainly not more than a week. We really start to run into the risk of that rebound congestion, and even worse. These can cause, like I said, the rebound swelling. So you're using them, and then you're doing great. And man, you just feel better. Your nasal passages feel clearer. But then you notice you got to start using a little bit more, and then a little bit more, and then a little bit more, because you're having some of that rebound. And in fact, you can get called, I think it's called rhinitis medicamentosa. Oh gosh, look that up. It's like rhinitis medicamentosa. It doesn't matter. It's what that means is you're overusing these medications, and now you've caused significant swelling in the nasal passages. And that will actually potentially need surgery. You can get online and look these surgeries up. They're a lot of fun. Make sure you do it during dinner with the whole family. It's fun for everybody to watch. They really have to get in there and surgically remove some of that tissue in order to help you clear those nasal passages. So you definitely don't want to use them for more than 3 to 5 days. If you need to use them longer than that, go talk to your doc. A nasal steroid may actually be a better option. So again, short-term use, 3 to 5 days is recommended. Certainly no more than a week. Those people that are using them for 2 to 3 weeks, much higher risk of having that rhinitis medicamentosa or whatever, and that rebound congestion. Do not use the two together. So if you're using systemic, stick with the systemic. If you're using the nasal, stick with the nasal, but don't use the two together. Don't take the systemic ones while using caffeine, and then always read labels, because that pseudoephedrine is sometimes in other over-the-counter medications, in those combos meds. Of course, they would know it because they would have to sign a waiver saying they can only have so much of this, but it's still important because we don't always get our medicines from the pharmacy. Sometimes we get them from friends and family, so make sure we're reading those labels. Okay, so if we need long-term relief from that inflammation in the nasal mucosa, it's the nasal steroids that we go to. These are specifically made for long-term. In fact, it usually takes a couple weeks for these to even start really working, or for you to really notice the effects. The most common ones that you'll see are fluticasone and budesonide. You can get these over the counter now. Triamcinolone, those is common as well. Fluticasone is also known as Flonase. I'm sure you've heard of that. Budesonide is known as Rhinocort. And then triamcinolone you'll see as nasal cort. There's others as well, but they all work basically the same. They block the inflammation in the nasal mucosa. And what we're using these for is that allergic rhinitis. So, people that have that constant congestion, a lot of times it's allergy related. These nasal steroids will help with that. They'll also help with nasal polyps. A couple things we got to watch for, though, with nasal steroids. They're usually fairly well tolerated because they're nasal and they don't usually get systemic, whereas we've already talked about systemic steroids can cause some problems. what we do need to watch for with this most common thing is irritation, and on top of that, nasal ulceration. So they can cause irritation to the nasal mucosa, and that can actually turn into nasal ulceration, at which point we would definitely want to stop. If we get an ulceration in our nose and continuing to put steroids on it, it will never heal, right? We've noticed that with steroids, that they block the healing. So these can unfortunately cause that nasal ulceration. We need to let people know, to let the doctor know if they start noticing bleeding or burning sensation in their noses, to let the doc know and take a look at that. They may need to stop that. Contraindicated then, of course, in a nasal ulceration or unhealed nasal wound. Interactions, I mean, in all honesty, these are topical. There's not a ton of interactions with the topical, unless they become systemic. It's potential they could become systemic, though, if you continue to take them while you have a nasal ulceration, though it wouldn't be a lot, but there's potential there. So again, just make sure we're really educating about those risks for nasal ulceration. So patient teaching. Administered daily. These are daily medicine, usually during allergy season. You usually take it through the whole allergy season. Then notify provider of that localized stinging or nosebleeds or symptoms of nasal ulceration. And then let them know it's going to take at least a week to start noticing positive effects. It can even take a couple weeks to really start noticing. If after 3 weeks they haven't noticed anything, then they probably need to go back and see the doctor and talk about other potential things that could be done for them. The steroid may not be working for them. Antihistamines. So we have a couple different generations of antihistamines. So what does that mean? The first generation, as far as our classic antihistamines, is diphenhydramine. There are other first generations, hydroxyzine, meclizine, but don't worry. Diphenhydramine at this moment is what I want you to know, and that's also known as Benadryl. Diphenhydramine is it's a common over-the-counter medication. We can take it for all kinds of things, and it's also very commonly found in combination meds as well, especially if it's a sleep aid, like Tylenol sleep aid, or if it says sleep aid, most commonly it has diphenhydramine in it. Our second generations are loratadine and cetirizine, also known as Claritin and Zyrtec. There's others. There's fexofenadine. There's definitely others. The most common right now, loratadine, cetirizine. Fexofenadine's coming on the way. It's now over the counter. So the way these work, though, they both work the same way, just one works a little bit better. They selectively block H1. So they're histamine blockers, H1 blockers, though. There's H2 blockers, and we'll talk about those when we get to the gastro medications. But for H1 blockers, we're worried about it's antihistamines. This is blocking that histamine, the effects of the histamine. So what's the difference between first generation and second generation? So they both block histamine to decrease that allergic response. Benadryl is actually going to do it a little bit better, but they also have greater adverse effects. The adverse effects related with these medications are anticholinergic effects and dizziness, drowsiness. Both generations could potentially give you those. However, Benadryl is much more likely to give that to you. But they also are better. So in emergent allergic situations, the doc's going to go with Benadryl. Probably have you give it to them IV or IM. Whereas just for everyday allergy relief, it's better to use the second generations because they have less potential adverse effects, or at least the adverse effects are less noted. However, they both have those potential effects. So our indication, seasonal allergies, cold symptoms, you'll sometimes see them used for that. Any sort of allergic reaction, especially with the Benadryl, just any sort of allergic reaction, they'll use Benadryl for, or I'm sorry, the diphenhydramine. And then also, though, we use these sometimes for motion sickness and sometimes for insomnia. Any sort of over-the-counter insomnia medicine, it's almost always got diphenhydramine in it. Not always. There's others as well that'll use different things, but almost always has diphenhydramine. Adverse effects. We talked about this a little bit on that last slide. Drowsiness and sedation. Either generation can potentially give that to you. Most commonly associated with Benadryl or diphenhydramine. And then anticholinergic effects. You know, they can't see, can't pee, can't spit, can't poop. Those classic anticholinergic effects. Contraindicated in kids less than 2, and also during pregnancy or lactation. With children, you may actually see a paradoxical effect. And what that means is we expect this to cause drowsiness and sedation. However, there's some people, but kids are more prone to it, that will have the exact opposite effect. So they will get very hyper, they get very active. So if you're one of those parents that's like, please kid, just go to bed, I'm just going to give them some Benadryl to knock them out, may not be the best idea for various reasons, one of which may be you may not get the wanted effect. So you may be up with a crazed kid instead of a kid that's just having a little trouble getting to sleep. And then be careful in people with renal or hepatic impairment. Interactions, anything else that's going to cause the CNS depression, like alcohol, and any other meds that we've talked about with the sedation, drowsiness. Patient teaching. Well, if it's causing those CNS effects, we know we need to alert them to avoid activities that require concentration. Avoid driving, operating heavy machinery. Avoid alcohol. Always read labels, because again, diphenhydramine is very common medicine in lots of the combination medications, especially those that are to help people sleep. And then, of course, just warn them about that paradoxical effect in children. Sometimes children have to take these, maybe for various reasons. They are having certain allergic reactions or whatnot. The doc tells them to give a little Benadryl. I've certainly had to do that with my daughters from time to time for various things. Just be aware. It's potential for that paradoxical effect. I've been lucky. My kids, the couple times that they've had to take it, didn't get that, jump off the walls paradoxical effect. But I certainly also wouldn't give it to them just to help them get to sleep. Expectorant. Expecto Patronum. Guafenazine. Wouldn't that be an interesting Patronus? Guafenazine, Mucinex. It reduces the adhesiveness of the respiratory fluids. So all that does is just help us cough that out easier. So it helps reduce the tension there in the lungs of that respiratory fluid, of that mucus, and allows us to get it out easier. So that's our indication, is a cough. But again, it's a cough that needs to get that junk out. So you can hear it in there, but they're not really coughing a lot up, right? So they've got like kind of a non-productive cough, but it's supposed to be productive. That will help loosen this up and get it going. Adverse effects. Most common is GI upset, nausea, maybe a little vomiting potentially. And then there's also a potential for a rash. You do see that sometimes with guafenazine. Patient teaching. I think I missed our interactions on that last one, didn't I? There's not really interactions, so don't worry so much about that. But do be careful in people that are pregnant or lactating. In children less than 6. So be careful in children less than 6 and pregnant and lactating. Patient teaching. The big thing to remember with this, so we're hoping to loosen those fluids to help get that out. So we need to drink plenty of water. So increase fluid intake. We're going to educate them on that. Make sure you increase your fluid intake. And then read your labels again. It's a common over-the-counter medicine. It's very commonly in those combo medicines. So if the combo medicine says anything about cough, you can best believe it's probably got some guafenazine in it. So make sure we're reading those labels. Mucolytic. Acetylcysteine. This is not over the counter. This is a medicine that we give in the hospital, and we have a couple different reasons for giving it. One action is it liquefies and loosens respiratory secretions. So whereas guafenazine helps reduce the surface tension and helps us cough that mucus up, this will just absolutely help liquefy it, help thin it out, and then we can really cough it up. So this is for people with like large amounts of thick secretion. Like people with like pneumonia or COPD and they're really having a tough time. Sometimes we'll give them acetylcysteine. When we're using it for that purpose, it's usually inhaled. It's a nebulized medication. There's another indication, and we give this one either PO or IV, and that's because it treats acetaminophen overdose. So this is the medicine I was telling you about. We've got to get to them most effective within, your book's going to tell you 8 to 10 hours. I've read 12. Certainly before 24 hours is best. Now, if they got there, before the 12 hours, that's optimal. Like that would be the best. If it's after that, within 24 hours, they still have we have a good chance of helping to protect that liver. Any more than that, and your chances of protecting the liver drop dramatically. The problem, of course, is if no one said anything, it takes 48 to 72 hours before you really start feeling the effects. At first, you'll feel the effects and just think maybe you're not feeling very good. Like, oh, I must have a stomach problem, or I've just maybe got a little stomach flu or something. Before you really realize how severe it is, at that point, it's too late, and it could be 48 to 72 hours. So most effective, again, your book's going to tell you about 8 to 10 hours. We're definitely going to certainly try before 24 hours. And again, it's used to protect the liver. There's 2 different ways to give it, PO or IV. The PO is preferred because there's a potential when you're given this either PO or especially IV. There is a potential there to cause an anaphylactic-like reaction. And it's much higher chance when we give it IV. However, the problem with it is it smells just awful. I mean, it literally smells like rotten eggs. Like it is god awful. The first time you ever have to open one of those, you'll just know I was not lying to you. It smells awful, and getting someone to drink that can be a challenge. However, I have had good luck by telling them that if they don't drink it, they may die, and that usually gets them through it. Usually Usually they're like, oh, you know what, I think I can handle this for a second. But, it may be so much that they literally just can't swallow it, and IV is potentially an option. Just know that there is that increased risk. It's not like it's crazy high, but there is an increased risk of that anaphylactic reaction or anaphylactic-like reaction with the IV. And again, that's our patient teaching. It smells awful. It smells absolutely awful. But this is the reason why you're taking it, and this is why it's so important for you. And if we're giving it for acetaminophen overdose, it's extremely important for them because this will help protect the liver. When acetaminophen breaks down, when your body breaks that down, metabolizes that, it makes a substance that is very damaging to the liver. We can usually clear that just fine, but only in certain amounts. Once we get so much of that in our system, our body's not able to clear that anymore. It just can't keep up. And then that will just start damaging the liver. And if it's a high enough amount, it's going to really damage the liver and cause liver failure. The only way to get, once the liver failure sets in, that's it, right? So really important to get this medicine on board, and we'll make sure we're educating people on that whenever we're giving it to them. But warn them, please warn them about that rotten egg smell. Oof, it's tough. All right, let's go with the lower respiratory tract. Common lower respiratory diseases: COPD, asthma, bronchitis, and pneumonia. COPD and asthma, obviously long-term. They're obstructive airway diseases. Bronchitis and pneumonia, a lot of times those are just acute. So let's talk about these a little bit. Xanthines. Xanthines are some of the first medicines that we gave for bronchodilation. They're pretty effective. We usually give them PO or IV. But there's some problems with these, and it'll make sense in a minute why we've gone to other medicines. The action, again, bronchodilation. Just relaxes those bronchial muscles, opens them up. An indication, those obstructive diseases, asthma, COPD. Again, they used to be the go-to, but they're no longer the go-to, and we'll talk about that. Adverse effects. GI upset, most common. Problem is narrow therapeutic range. So then we can start getting into toxicity. Then we start getting irritability and restlessness. Can progress into arrhythmias and seizures, brain damage, and then death. Obviously, let's hope we catch it before then, but we can see, again, narrow therapeutic range, toxicity can be deadly. We can kind of understand why maybe these aren't the go-to anymore. Be careful in people with hypertension. And as far as the hypertension goes, that could be a contraindication depending on how controlled it is. Heart disease, diabetes even, renal or hepatic disease. Interactions. There's a lot of drugs that can interact with these, but there's two drugs we absolutely have to talk about because they are so common. In fact, they're so common, many of you have probably had them today. One is nicotine. It can interact with nicotine. And the other is caffeine, which obviously is extremely common. That I do know that Starbucks puts in their coffee. I know that one's in there. The Tylenol may have been a joke. The caffeine, obviously, we got it. It's in everything. And now they put caffeine in everything again, right? So it's in all our sodas, but it's also in all the energy drinks and all kinds of stuff. I've seen caffeinated gum. They really do put caffeine in everything. The problem with this is it increases the metabolism of the xanthines in the liver. So we need an increased dose in order to work. So if you're not smoking the same amount, so if you're smoking a pack a day every single day, and you're using the same amount of xanthine, then it supposedly should be okay. But if you decide one day, yeah, I'm gonna quit smoking, and you're still taking the same amount of xanthine, now we have a potential for increased toxicity. Or if you just don't feel like smoking a pack that day, you just smoke a half pack. We have a potential for toxicity. The best practice is to stop smoking. Caffeine, again, the best practice is avoid caffeine. Certainly, if they have to be on these and absolutely can't, they need to make sure they're doing the same amount each day, but that's so hard to do. So best practice would be just to avoid caffeine and avoid smoking. Take as directed. Let me get to patient teaching. Patient teaching, so take as directed. If you miss a dose, though, don't make it up. Get lab work. Again, they're going to need lab work. We got that narrow therapeutic range. We have to make sure that they're staying in that range. And then, of course, avoid caffeine and nicotine. You can see why we don't use these much anymore. They still are used, though. So it's not like you don't need to know them, because you will still see these from time to time. Beta-2 agonists. These are the go-to bronchodilators. These are the ones that we use. You'll use them all the time. Albuterol, levalbuterol. There's others for sure. I've got epinephrine on there. Epinephrine it's actually a total adrenergic agonist. It's gonna get them all, right? Whereas albuterol is specific to beta-2. Again, stimulates those adrenergic receptors and causes bronchodilation. Adverse effects: tachycardia, restlessness, nervousness, maybe a little fine tremor. It's contraindicated. Okay, so the thing about contraindication and caution, it's all about severity, especially with these medicines, because these medicines are life-saving medicines, right? I mean, these cause bronchodilation. People that are having difficulty breathing, they need a bronchodilator. And usually it's this beta-2 agonist. So we will certainly be careful in people with history of hypertension or coronary artery disease or arrhythmias. But depending on the severity of that situation and the severity of the condition itself, it's always a risk-benefit. So if someone's a little tachycardic, I'm going to talk to the doc real quick and say, hey, look, this is, what do we, okay, good. Okay, good. Let's do it. If they've got an arrhythmia, I'm going to make sure I'm checking real quick. But I know that it's not absolutely contraindicated. I just know that I need to make sure I'm careful and that I'm discussing this with the provider and make sure we're all on the same board with the risk benefits. Because if they're really not breathing, it's all about ABCs. We know, man, we got to get that going, and then maybe we can figure out the rest later. So again, the contraindications, just put down, it depends on the severity of the condition. So whatever's happening to the patient. So we're going to be careful with arrhythmias, coronary artery disease, hypertension, but it's all risk-benefit type thing. These can be life-saving medicines. So we're just going to kind of watch those. But we do know to watch that. Interactions. So let's think about interactions. Oh, I left my interaction stage or page before I discussed it, but let's discuss it real quick here. If it's a beta agonist, you already know one interaction, beta blocker. Another potential interaction is an MAOI. We will discuss MAOIs later, and it will make a lot more sense why MAOIs interact with lots of things. Patient teaching. We need to teach them how to take it. It's usually either inhaler or nebulizer, which is still an inhaled medication. It's just through a different device. If it's an inhaler, we need to teach them the proper way to use that inhaler. The best practice, as far as what recommendations are concerned, is with a spacer. You use the spacer because that allows you to get the most medicine down into the lungs. People that just throw the inhaler in their mouth and spray it, a lot of times it's just spraying it in the back of the throat or on the roof of the mouth. That medicine sticks there. Once it sticks there, you can't inhale it. It does nothing for you. So there needs to be a little bit of space there. The spacer's the best practice. As far as the nebulizer go, we'll teach them to how to set that up and make sure that they understand how to utilize it appropriately, to make sure that they keep that in their mouth or over their mouth, whether it's the mask or the little mouthpiece, and to inhale the medicine. I know that sounds goofy to say that, but it's true. A lot of times people will have that mouthpiece and they'll be sitting there just yakking away at somebody with the mouthpiece over to the side. And it's like, dude, you need that. That medicine's just, it's just going there. It's not doing anything for you. You need to put that in your mouth. Don't worry about talking right now. Just get this medicine in. We're going to teach them how, or I'm sorry, we already talked about how, but when to take it. Sometimes this is taken multiple times a day for to keep their lungs dilated, and sometimes it's for PRN purposes. Sometimes it's just when you need it. So we'll teach them that. If it's 1 to 2 puffs every 4 hours, then that's what they need to take. And if they need to take more than that, then they need to go get help, and probably very quickly, because there could be something else going on that's causing exacerbation. So we'll teach them about that. Okay, take it as directed. If you need more than that, get a hold of your doctor immediately or go to the emergency room depending on the severity of what's going on. We'll teach them about the adverse effects. Look, this is probably going to make you a little nervous, maybe give you a little tremor, give you you may even feel, your heart race a little bit. And then, of course, just like when I talked about the scheduling, make sure they understand, don't take more than instructed, right? So my classic picture of the MDI inhaler is Goonies, right? Sean Astin's character, he probably uses that inhaler about 7,000 times through that movie. It's only like 2-hour movies, so he's clearly going over the recommended amount. He probably needs to go see a doctor. Let's just let One Eye Willie's been there for 100 years or so. He's going to be fine. Go see your doctor and then maybe come back later. He's also throwing it in the back of his mouth, right? He's not. That's probably why he's using 7,000 doses, because he just keeps throwing it in the back of his mouth. He's not even really breathing it in. So let's try to teach people to maybe utilize it a little bit better than Sean Astin's character did. Anticholinergics. All right, so the beta agonist, your beta 2 agonist, your albuterol, levalbuterol, those are your rescue right now. I need help right this second medicines. Those are your number one medicines. So if you're giving medicines or if you're giving multiple of these medicines, always start with the beta 2, always. Second will be your anticholinergic. It's going to cause bronchodilation. It's just going to do it through the PNS, and by doing so, that causes that takes longer. It's not going to be as quick. Whereas a beta agonist, that's your sympathetic nervous system. So if we can agonize that, stimulate that, it's going to go right this second. So beta 2 agonist, right this second. Anticholinergic, going to take a little bit longer, but still going to cause that bronchodilation. Ipratropium, tiotropium are your classic anticholinergic medications. You will sometimes see these, actually I won't say sometimes, you'll see them a lot combined with the beta 2 agonist, at which point you just give that one, obviously, because it's got both your 1 and your 2, your beta 2 agonist and your anticholinergic. However, if they're separated, if there's one, if you're going to give the albuterol and then also supposed to give the ipratropium, you're going to give the albuterol first every time, and then you're going to follow it up with the anticholinergic. Action, again, bronchodilation, relaxes that smooth muscle. Indication, COPD, asthma, same as our, or any sort. If there anything that's causing that bronchoconstriction there, you will use this again after the beta 2, but classically it's COPD, asthma. Adverse effects. Well, it's called an anticholinergic medicine, so that already tells you the adverse effects. Anticholinergic. So dry mouth, constipation, urinary retention. It can also cause a little bit of nervousness and sometimes palpitations. This one also can potentially increase heart rate. That's another anticholinergic effect. We think of the classic anticholinergic effects as can't see, can't pee, can't spit, can't poop, but it also causes an increase in pulse as well, especially when we take it systemically. So just kind of be aware of that. Be careful in people with glaucoma or BPH, because again, we're causing some of that those problems like with the urinary retention. And then interactions, any other anticholinergic. So it could potentially, if you're taking multiple anticholinergic medications, we can obviously, the potential of those adverse effects just increase. Patient teaching. So again, take second. This is not for an acute bronchospasm. So if you have this as a nebulizer, we'll want to make sure when we teach them about it, look, if you're having an acute problem, go to your PRN beta agonist, your albuterol or whatever it is that you're giving them. Do not use this as your rescue. This is not a rescue medication. So it's not for acute bronchospasm. We're going to teach them, take this second. Take the beta agonist first and then the anticholinergic second. It's very common that the two have been put together. So if that's the case, obviously, then that's the one they use. Rinse mouth after inhalation. I should have said that with the beta agonist as well. Every time that they use these, they need to rinse the mouth out. And then they need to wait 5 minutes before doing the next medicine. So let's talk about this. So they do the beta agonist first, right? We talked about that. You do the beta agonist first because that's the one that's going to act right now. It's going to cause the bronchodilation right this second. And then rinse your mouth and wait about 5 minutes and then do the anticholinergic medication. Then rinse your mouth, wait about 5 minutes, and then you can do your steroid. We'll talk about steroids next. But that's how we'll tell them to take it. So beta agonist first, anticholinergic second, and inhaled steroid third. Budesonide and fluticasone are your common inhaled steroids. Fluticasone is the most common. This one works. The way that this is going to open up the airways is by actually decreasing inflammation, and that takes much longer than the bronchodilators, the anticholinergic, and the beta agonists. Beta agonist is going to cause the bronchodilation right now. It's going to stimulate that sympathetic nervous system. That's going to open up the bronchioles right this second. Anticholinergics, they're going to do that through the PNS, so it's kind of like it takes a little bit longer to get that going, but once that goes, at least it does open them up. It causes bronchodilation. It's at least quicker than the steroids. The steroids decrease inflammation. That's a much longer process. It's going to take much longer for these to really start working. So this is why we take these last, if we're taking all three of them together. Indication, asthma, COPD, just like we talked with the others. Adverse effects, well, it's a steroid, so there's potential there for the immune suppression. But most commonly, the adverse effects you're going to see, hoarseness or cough, and thrush or oral candidiasis. Those are the more common adverse effects, but certainly immunosuppression's there. Cautions, be careful with children, people with infections, especially respiratory infections. And then interactions, other steroids, and then of course diabetic medications, we can potentially cause some interactions there. Patient teaching. Again, big thing, not for acute asthma attack. This is not an acute medication. This one you take last. If you're taking all three of them, you're supposed to take this one at the end. Obviously, start with the beta agonist because that's going to give you the right now relief, and then do the anticholinergic after 5 minutes, and then again wait another 5 minutes and do your steroids. Make sure you're rinsing your mouth. This one's really important to make sure you're rinsing your mouth after, because we have that potential thrush, right? We got to rinse our mouth after this one. And that's our major patient teaching with inhaled steroids. These are some combination respiratory medicines. You'll see these. Advair's that little discus. Combivent, that's a duoneb. It can be given a few different ways. Symbicort. These are just common respiratory combination meds. So our Symbicort, let's talk about that. That is budesonide and formoterol. Formoterol is F-O-R-M O-T-E-R-O-L. So F-O-R-M-O-T-E-R-O-L. And then, of course, the budesonide. Advair is fluticasone and salmeterol. So S-A-L-M-E-T-E-R-O-L. S-A-L-M-E-T-E-R-O-L. And then the Combivent is albuterol and ipratropium. You should have both of those. You should know what those both are, ipratropium and albuterol. Here's some delivery devices. MDI, that's the classic inhaler. Remember, we need to use a spacer with that. Next to that is the nebulizer. She's wearing a face mask. Face masks are generally used for children. And then, of course, anyone that can't hold the mouthpiece up, or, you know, if you decide that face mask would be best for them, then by all means put the face mask on. The discus, that's commonly Advair. The thing about that discus is that has powder in it. So it cannot get wet. It needs to be kept in a dry environment. Make sure that it doesn't get wet and clump up, because if it does, then it's useless. And those things are expensive. The HandiHaler there, that actually is a pill. You take it, there's a pill that goes in that, and then you puncture the pill and you breathe it in. And then that last one's actually, it's a specific type of inhaler. That one releases the medicine very slowly, which is awesome, because that allows you to breathe in more of that medicine, actually get that medicine down into the lungs deeper, without the spacer even. Whereas the MDI just is a quick puff, just a quick puff. It's all laid out there, right? The other slowly releases it. Leukotriene receptor antagonists. Montelukast, that's also known as Singulair. You will see this from time to time. It's taken PO. This one blocks the effects of leukotrienes, so it decreases inflammation. We use this for asthma, or including exercise-induced asthma. And that's the adverse effect. It can actually give you some flu-like symptoms. Some people experience just some like fever or just generalized muscle pain with it. But it also can cause liver injury, so we got to be careful of that. Be really careful with people with a history of liver injury or even current liver problems. And it's going to interact potentially with theophylline and warfarin. Patient teaching. Take at night. It's not for an acute asthma attack, so this isn't a rescue medication. And then it also doesn't substitute for our other asthma medicines. It just helps. We still need to continue taking those other asthma medications as prescribed by the doc. Now, the doc may make a couple of changes, but you still have to take those medicines as directed by the doctor.